You're muted.
Yeah, Dr. Wallach, I can't hear you.
Got my screen?
Yes, we can see your screen.
Yep.
Okay. So hepatitis B. Today will be hepatitis B, and then on Wednesday we're going to do hepatitis C. We don't see a lot, but I think it's important to know some of the key aspects of it. And certainly the prevalence of the disease is shown here throughout the world is such that obviously the areas in gray where there's a very low prevalence, and that is, of course, related to newborn vaccination. I'm interested to see what our current head of Health and Human Services is going to do about the Hep B vaccine. It might be very interesting to see what happens over time. Not pleasurably interesting, but interesting nonetheless. And so if you are going to see patients with hepatitis B, they'll almost certainly be either first generation or immigrant children themselves, because of vaccination, the prevalence of hepatitis B in native-born Americans is virtually nil. So there are 400 million cases worldwide, and again, about 1 million in the USA. But at the time I made this slide, it was up to 70% were immigrants. I think it's much higher than that now. And the vast majority are going to come from Eastern Asia, especially Korean, Chinese, and Vietnamese Americans. So in much of the world, the lifetime risk of contracting HBV is about 60%. A universal infant vaccination was instituted in 1991. Again, who knows what's going to happen going forward. If any of you tend to go on LinkedIn, Dr. Wallach has some very interesting comments on LinkedIn regarding the current state of the NIH and the leadership thereof. So it might be worthwhile you looking at what Dr. Wallach has written. So certainly because of vaccination, the incidence of acute hepatitis B has declined significantly, but chronic Hep B remains a problem because of vertical transmission. Again, immigration from areas of endemic disease, and certainly infections because of infected household contacts. So importantly, when one develops HBV as a newborn, 90% of the time, when you get chronic HBV, 90% of infants infected as neonates develop chronic HBV, and 25 to 50% of older children in the toddler, young child age group who are acutely infected will develop chronic HBV. So in the old days, genotype was extremely important in terms of gauging the response to therapy. No longer is, although as you'll see, the genotype certainly informs on the risk for developing complications related to HBV, particularly hepatocellular carcinoma. There are subgenotypes that have minor divergence in genotype. When they have greater than 8% divergence, that will inform on a separate genotype. And again, disease outcome in terms of risk appears to be strongly associated with HBV genotype, although the response to therapy does not appear to be directly related to genotype, with current therapies, that is. Genotypes are important when considering risk because they diverge based on the country of origin. The vast majority of patients that you will see, again, coming from the eastern part of Asia, will be genotype B and C, and we'll say more about these genotypes later in the lecture. And you can see the wide variety of genotypes in areas of low endemicity, because again, this is going to be reflective of the national origin of the subjects who could contract the disease. So the learning objectives obviously surround how do we identify, how do we manage, and what is the outcome. So what is the evidence that treatment improves outcome? Who should be treated? When should treatment be initiated? How long should antiviral treatment be given? And how do we deal with antiviral resistance? The last question obviously has been answered by the new drugs, where, as you will see, there is so far zero resistance, but we'll get to that later on. So the largest proportion of children and young adults with chronic Hep B are in what is known as the immune tolerant phase of the natural history of infection. And what does immune tolerant means? It means they have very high viral loads, 10 to the 10th, 10 to the 12th, but normal transaminases. The level of viremia during immunotolerance is probably not predictive of risk of liver disease or hepatocellular carcinoma, although there is some evidence that we will see that very high levels of virus over a very long period of time may increase risk. Therein lies the controversy as to who should be treated. And the reason why these patients have not been treated in the past is that for those in the immune tolerant phase, therapies are largely ineffective at that stage of disease. Children with consistently elevated transaminases, or those with a family history of hepatocellular carcinoma, should be certainly considered for treatment. So this is the virion. It's a 42 nanometer particle comprising an outer envelope with the business end of the virus, the genome internally. And you can see here the EM view of the virion. So there are 4 genes comprising the virus, S, P, C, and X. The S gene codes for the surface antigen, that's the envelope protein. The largest gene codes for DNA polymerase. The C gene, core gene, codes for core antigen and E antigen. This C gene has a pre-core and a core region, and the significance of the pre-core and the core region will become obvious to you as we go on. If translation of the genome is initiated at the pre-core region, the protein product is E antigen. If translation begins with the core region, core antigen is the only protein product of this gene. So HBe antigen is a marker of HBV replication and infectivity. The higher your E antigen level, the greater is the virus replication and infectious potential. The pre-core region is not necessary for viral replication. Pre-core mutants can replicate, but in those cases, they don't produce E antigen, so there is no specific marker that codes for replication and infectivity. These pre-core mutants are readily detectable by analyzing HBV DNA in the serum, but again, E antigen is absent in these pre-core mutants. This is, again, a figure which shows you the genome. And this is called the reading frame, or the open reading frames of the HBV genome. The open reading frame is the part of the reading frame that can be translated. It is a continuous stretch of codons. Remember, codons are 3 nucleotide residues that begin with a start codon, adenine, thymine, guanine, and ends at a stop codon, thymidine, adenine, guanine. So again, for the genome, when you have ATG, that tells the gene to start translating. And when you get to TAG, it says stop. The open reading frames of the surface antigen are shown here, and they code for 3 lengths of surface antigen. These are of interest, but are not of therapeutic significance. So you can have a small s, a middle s, and a large s, depending upon where the reading frame starts to be translated. The life cycle of the HBV is described here, and I'll show you a slide which gives you sort of a cartoon version of this. So the first thing that happens is the virus gains entry into the cell by binding to a cell surface receptor. That receptor is the sodium bile acid co-transporting protein, or NTCP, and it enters through endocytosis. As you know, endocytosis involves an invagination of the cell membrane surrounding the particle that enters the cell. The virus membrane fuses with the host cell membrane and releases the DNA and core proteins into the cytoplasm. Obviously, in order to read the DNA, you have to uncoat the virus. So because the virus multiplies via RNA by a host enzyme, the viral genomic DNA has to be transferred to the cell nucleus. The core proteins dissociate from the partially double-stranded viral DNA, which is made fully double-stranded by the host DNA polymerase. So this all has to take place in the nucleus of the cell. And then the DNA becomes a covalently closed circular DNA, and this serves as a template for transcription of 4 viral mRNAs that are responsible for synthesizing the remainder of the virus. The largest mRNA is used to make new copies of the genome and to make the core protein and the viral RNA-dependent DNA polymerase. All of this then undergoes viral assembly in the Golgi, and then it's released. So here is just a view of what happens. You have the HBV DNA shown at the top here. It enters into the cell. Here you have the core particle, which enters the nucleus, all right? And then it's repaired and becomes covalently closed circular DNA, is transcribed, is transported out of the nucleus where it's translated, and the virus is synthesized. Here we have budding into the endoplasmic reticulum. This is then put together. It's transported to the cell membrane, and then by exocytosis, it exits. Very neat, very clean, but again, it requires the host enzyme to complete the process. The pre-core region, from a diagnosis and management standpoint, is extremely important. Remember, we talked about the pre-core mutant and how the pre-core mutant does not produce E antigen. And here's what happens where you have a stop codon in the pre-core region. Remember, ATG, TAG. Well, here you have the pre-core region, and it says start. But when you have a mutation somewhere in the pre-core region from TGG to TAG, remember, TAG is stop, so it's stopped. And so we don't produce E antigen because, remember, E antigen requires translation of the entire pre-core region. So here we have the stop codon, and then we go down and down and down. Here's another ATG. We start again, and now we produce the core antigen. So the pre-core mutant doesn't produce the E antigen, but does produce the core antigen. Remember again, ATG is the initiation codon, TAG is the stop codon. So this pre-core mutant, again, is a variety of HBV that doesn't produce E antigen and involves a change in the DNA basis from TGG to TAG, again, producing a stop codon. These pre-core mutants may be more difficult to treat, may result in a prolonged duration of infection, and have a higher risk of liver cirrhosis. So again, this is the group that you will be most worried about in terms of their response to therapy. There's another kind of mutation, and this is called a basal core promoter mutant. A basal core promoter mutation is a point mutations in the promoter for E antigen and core protein mRNAs. They express less E antigen but still produce E antigen. However, these basal core promoter mutants are associated with enhanced viral genome replication, and that enhanced replication is a major risk factor for hepatocellular carcinoma. There are a wide variety of mutations that are shown here. These include those that affect serological markers, viral clearance, drug resistance, and in the old days, we used to worry about non-responsiveness to interferon therapy. We don't use interferon anymore, so that's really not an issue. But the pre-core mutant and the basal core promoter mutation have a reduced or absent production of E antigen, and this is the group we're most concerned about. This is a graph which looks at the percent of patients who develop either chronic carriage of the virus or hepatocellular carcinoma. And they're divided into whether they're a pre-core wild type or mutated, or a basal core promoter wild type or mutated. So over to the left, when both the basal core promoter and pre-core region are of the wild type, very high percentage are chronic carriers of virus, but a very low percentage develop hepatocellular carcinoma. Let's move over all the way to the right, where you have the wild type pre-core region plus a basal core promoter mutation. That is the group that has the highest risk of developing hepatocellular carcinoma. And certainly that is the group that you want to be most concerned about when trying to determine whether you require therapy. All of these basal core promoter mutations, and they're shown to the right, have a much higher likelihood of developing hepatocellular carcinoma than do the wild type basal core promoter. So what about E antigen? What's so important about it? Well, we really don't know. Its function is not clear. It plays no role in viral assembly. It's not required for replication. And pre-core mutants arise frequently during natural infection, and they are an indicator of viral replication and infectivity, but we really don't know what the E antigen precisely does. So what is the natural history of the disease? Well, I've shown you two graphs here. The one to the left is acute disease, which results in recovery. The one to the right is chronic disease. So very early in the course, after an incubation period of 4 to 26 weeks, you have a rapid rise in serum transaminases. This occurs in association with the appearance of the E antigen, HBV DNA, and surface antigen. Then, over time, we start to develop antibodies, initially anti-HB core IgM and anti-HBe. At the same time that these antibodies are increasing, your transaminases start to drop and you lose your HBe antigen, your DNA goes down, and your surface antigen is lost. While they are lost, now you start to produce IgG to surface antigen and IgG to core protein. So when you say these developed here, we no longer have transaminasemia, we no longer see viral markers, we are cured. But what happens in the chronic condition? In the chronic condition, here we have the transaminases, and they remain elevated to a variable degree. And while they remain elevated, or even when they become back to normal, we still have a persistence of e antigen, HBV DNA, and surface antigen. At some point, theoretically, months to years later, the hope is that you start to produce antibodies to surface antigen and to core, and ultimately clear your disease. But that's highly variable, and that's a process that can take years to develop. The phases of chronic HBV infection are shown here. Remember, I discussed early on the immune tolerant phase. The typical HBV DNA is often greater than 10 to the 7th, 10 to the 8th. We commonly see 10 to the 10th, 10 to the 12th. All right? These patients, unless they're pre-core mutants, are HBe antigen positive, their ALT is normal, and their liver biopsy is typically normal or with minimal findings. Although we don't generally perform liver biopsy on these patients anymore, I will show you some biopsies later on. These patients are generally not considered to be treatment candidates. The next phase to consider is the immune active phase. This is the immune active phase in e antigen positive chronic Hep B. They also will have elevated DNA, but to a lesser degree than the immune tolerant patients. E antigen is positive. Their ALT is either persistently elevated or fluctuating. These patients will demonstrate active inflammation on liver biopsy, and these are considered treatment candidates. Then we have the inactive carrier. The inactive carrier is a patient, as the name suggests, who's carrying the virus, but the virus tends to be non-replicative. It just seems to be floating around, minding its own business without replicating itself to a great degree. So typically, HBV is very low, e antigen is negative, ALT is normal. Surface antigen may become undetectable. These patients, again, are not treatment candidates. And then we have the e antigen negative chronic Hep B. So this is the pre-core mutant situation. They tend to have lower levels of DNA, so don't let the level of DNA fool you. Just because someone has a very high level of DNA, let's go over to the highest level, that's the immune tolerant phase, doesn't mean they're candidates for therapy. These patients are negative e antigen. They will have elevated or fluctuating ALT. They will have inflammation on biopsy, and they are treatment candidates. So this is probably the one group that you might want to consider doing a liver biopsy because of the unclear nature of what's going on in the e antigen negative scenario. So how do we interpret serological results? Again, for those of you interested in taking the boards, this is a favorite board question. They'll give you a number of serological results. Now, what does that mean? Well, if surface antigen is negative, core is negative, and anti-surface antigen is negative, so everything is negative, you offer this patient vaccination because they've not been exposed. If HBsAg is negative, total anti-HBC is positive. I can't talk now, sweetie. I'll call you later. And anti-HBs is positive. I'm sorry. If HBsAg is negative, anti-core is positive, anti-surface antigen is positive. This is a person who's had natural infection and is immune. If surface antigen is negative, total core is negative, and anti-HBs is positive, that's immune. because of vaccination. Remember, the vaccination is against HBS, not against core. If HBsAg is positive, anti-HBC is positive, anti-IgM, anti-HBC is negative, and anti-HBS is negative, that's your chronic infection. Only surface antigen and anti-core is positive. If the first three are positive and anti-HBS is negative, that's acute infection. If surface antigen is negative, anti-HBC is positive, and anti-HBS is negative, that's unclear, and you probably want to repeat the test after a while. So this is a graph which you should look up. It's in any text you want to read on hepatitis B. This is something you'll need to know.
Dr. Schwartz, is the total anti-HBC, the one that's not IgM, is that IgG?
IgM.
So there's one that's IgM.
Anti-HBC. The total anti-HBC is IgG plus IgM.
It's IgG plus IgM. Okay.
All right. This is just the IgM. Remember, IgM is your early antibody.
Sure.
So, someone want to explain to me what this slide is? See anything unusual in this slide?
Some of the hepatocytes look like they have a ground glass appearance.
Ah, ground glass appearance. That's your tip. You know what the ground glass is?
Virions?
Surface antigen. All right, this is surface antigen. And this ultimately becomes something called a Councilman body. A Councilman body is deeply eosinophilic material, which represents an apoptotic or dying cell. And this is a better view of a Councilman body. All right, this is a cell that's dying. What happens when cells die? Here's another one. What happens when cells die? Well, inflammation occurs, fibrosis occurs, and that occurs. So again, it goes from the ground glass hepatocyte to the Councilman body to inflammation to cirrhosis. So again, I showed you the various phases. Now, what are the typical diagnostic criteria? For patients you diagnose with chronic hepatitis B, they should demonstrate surface antigen positivity for more than 6 months. Typically, their HBV DNA is greater than 10 to the 5th copies per ml. Remember, with pre-core mutant disease, the value is lower. They have persistent or intermittent elevation in transaminases, and their liver biopsy will show chronic hepatitis. In the carrier state, again, surface antigen positivity for more than 6 months. They can be e antigen negative. They're generally e antigen negative and anti-HBe positive, but they still have a very low level of HBV DNA with persistently normal transaminases. And if you biopsy these patients, there would not be significant hepatitis. Then you have the resolved Hep B. They have a previous history of acute or chronic hepatitis B. They have undetectable DNA and normal ALT. The natural progression, again, for the patients you are likely to see, may involve perinatal transmission, which initially goes to the immune tolerant phase. And this is going to be the vast majority of patients you see. Those children who have immigrated to the United States from an endemic country, most of these children will have contracted the virus perinatally, and so will be 90 to 100% will be in the immune tolerant phase, and then they ultimately can get to an immune active phase. How and when that occurs is highly variable. Patients who have horizontal transmission rather than vertical transmission generally immediately go into an immune active phase. And 90% will seroconvert to anti-HBe positive. But of those that seroconvert, some of them will backslide back into an immune active phase. Once they achieve seroconversion, if they don't go back, then they'll develop ultimately inactive HBV, or 10 to 20% will remain immune active. And of those that have inactive HBV, about 0.5 to 1% per year will clear their surface antigen. So in other words, when you see a patient with chronic Hep B, there's, depending upon how long they've had their disease, there's a perhaps 1% chance each year that they will clear their virus. The hierarchy of HBV seroconversion, therefore, takes not months, not weeks, but years and years and years. Initially, you have an immune active phase resulting in the disappearance of HBe antigen. Again, here it's shown a timeline 6 to 12 months. 1 to 2 years, you start to develop anti-HBe, and then in a period of years, the disappearance of surface antigen. This would be the ideal situation where you ultimately clear your virus endogenously. But most of our subjects will not do that within the time frame that we follow them. So we have to decide on when and whom to treat. The goals of therapy are to permanently suppress viral replication, prevent disease progression, and prolong survival. The markers for treatment success involve 1, an undetectable DNA, normalization of transaminases, improvement of histology where investigated, the loss of HBe antigen related to therapy, not related to precore mutation, and ultimately the loss of surface antigen. Controversy remains in pediatric chronic Hep B patients. Who should be treated? When should treatment be initiated? How long should patients be treated? And how do we treat resistance when and if it occurs? As I showed you earlier, there are 8 known genotypes. The majority of cases of perinatal transmission is genotype C. And if you look at the age of HBe antigen clearance, it's the longest for those who have genotype C. Surface antigen conversion, remember B and C are the predominant ones coming from Asia. Seroconversion occurs earlier with B than with C. The therapeutic response to interferon is there just for your interest, but we don't use the drug anymore. If you want to look a little bit at the history of treatment, you can read about interferon therapy. Now, the progression of the disease and the increased risk for hepatocellular carcinoma, C is greater than B. Although therapeutic decisions in children cannot be based on genotype at present, it is worthwhile if you see a patient whose family or who has immigrated to the United States from China, Korea, Japan, anywhere in East Asia. It is of some importance to do a genotype, because if they have genotype C, this is particularly a high-risk group for hepatocellular carcinoma. And one of our former colleagues at Downstate, Dr. Zhu, diagnosed a patient with hepatocellular carcinoma just based upon the genotype. He did a genotype, found this patient was Hep C, immediately did a serological marker as well as an ultrasound evaluation, and the patient did have hepatocellular carcinoma, which was successfully resected. So when you have patients emigrating from these areas of high endemicity with a high likelihood of having genotype C, they should be genotyped. Now, one of the things I mentioned earlier was what is the significance of high levels of virus? Well, there have been some studies that show that high levels of surface antigen increase the risk of hepatocellular carcinoma in patients with a low viral load. Again, these are pre-core mutants, so who have a low viral load, but are genotype, largely genotype C, with high levels of surface antigen. The risk factors for hepatocellular carcinoma in children are shown to the right. Males, patients with cirrhosis, again, genotype C. The basal core promoter mutation that I showed you earlier is the most important mutation when trying to determine whether or not a patient is at risk for developing hepatocellular carcinoma. Patients who have early e antigen seroconversion. Early e antigen seroconversion does not mean natural history. It generally means the development of a pre-core mutation, and certainly those with a family history of hepatocellular carcinoma. So these areas to the right in the yellow box are very important for you to recognize, because these are the patients who need to be closely monitored for the possible development of hepatocellular carcinoma. So, how do we manage these patients? Well, let's first look at the e antigen positive group. This is a group of patients who are surface antigen positive, that's the initial study, and they're e antigen positive. They're e antigen positive with a normal ALT. If they have a normal ALT, you want to check them every 3 to 6 months, and every 6 to 12 months do their e antigen. If their ALT is 1 to 2 times the upper limit of normal, check their ALT again in 3 months. Again, 6 months e antigen. Consider a biopsy if this is persistent. All right. So this is the patient where treatment is unclear, and you may want to biopsy these patients. When the ALT is greater than 2 times the upper limit of normal, again, you want to don't initially treat them. You want to reevaluate them after a few months, as well as doing an e antigen. If the ALT is persistently elevated, and you're going to treat them. A liver biopsy is optional in this group. We generally don't do that. However, if they become jaundiced or have evidence of decompensation, you want to treat them immediately. What about the e antigen negative situation? Again, natural history versus pre-core mutation. Well, if the ALT is greater than twice normal and the HBV is greater than 20,000 international units per ml, you're going to treat them. If it's 1 to 2 times the upper limit of normal with a lower HBV DNA, again, this is the group you're going to monitor and consider the biopsy. If their ALT is normal and their HBV is less than 2,000, you're going to monitor them because these are the patients who may be clearing their virus naturally. What we do know is, despite some of the evidence for the pre-core mutation, as I showed you earlier, where e antigen negativity may inform on the risk for hepatocellular carcinoma, during the immune tolerant phase, there is very little progression. So these are the initial liver biopsy of this group of patients is shown to the left. The follow-up liver biopsy is shown to the right. And you have the fibrosis stage, lowest grade, medium grade, and higher grade. And you can see very few patients have progressed during a 5-year follow-up period in the immune tolerant phase. So this is one of the reasons, or one of the main reasons, why we generally don't treat these patients, because they really don't progress. Furthermore, they tend not to respond if you do treat them. Again, during the immune tolerant phase, there is minimal disease progression, but we also know that on the flip side, that persistently elevated DNA may be associated with increased hepatocellular carcinoma risk. But again, this combines both the pre-core mutant and the normal group. But again, this just requires close monitoring, particularly of high-risk patients. And again, here, this study did not divide patients among genotype, which is extremely important when determining risk. The treatment landscape has increased dramatically over the last 30 years. And so when Dr. Rabinowitz and I were in training, really what we had was interferon. Interferon is a drug which could be effective, particularly in patients with specific genotypes, but obviously associated with a huge number of side effects. And this, after a while, we had development of the newer antiviral drugs, beginning with lamivudine, adefovir, and entecavir, and then here we have pegylated interferon, which required fewer injections, telbuvudine, and the newest kid on the block, tenofovir, which is now pretty much, as you will see, the treatment of choice for all subjects. The first branch point in choosing what to treat is which arm do we go on? Well, this arm no longer exists. We're really going to what are the nucleoside or nucleotide analogs. So just a little bit of his history on pegylated interferon. Only 30% of these e antigen positive patients achieve seroconversion. It was recommended for patients with very high ALT levels and particularly those with genotype A. When it came to interferon, genotype was very important in predicting the response to therapy. In patients who were on interferon, after 12 weeks, if they didn't respond, treatment was considered futile. Currently, we only use the nucleotide or nucleoside analogs for the vast majority of patients. A nucleoside is a nucleobase linked to a sugar. A nucleotide is a nucleoside with a phosphate group. So nucleosides are phosphorylated by cell kinases to produce nucleotides. So when you give a nucleotide, you're actually giving what a nucleoside ultimately becomes. And these nucleotides are the molecular building blocks of DNA and RNA. And what they do is they replace the normal building blocks and block the synthesis of DNA and RNA. And here are the major nucleoside and nucleotide analogs. To the left, we have lamivudine, clevudine, tilbutavine, and entecavir. These are nucleosides. And when you add a phosphate group, you get adefovir and tenofovir. Very similar, but here you have the addition of the phosphate group, which makes a nucleoside a nucleotide. The second branch point is, well, we've already decided we're going to use a nucleoside or nucleotide analog. We then have to see, do we choose lamivudine, adefovir, entecavir, telbivudine, or tenofovir? As I mentioned earlier, the mechanism of action is to interfere with the transcription of DNA and RNA. So here we have the nucleoside analog or nucleotide analog, which ultimately blocks a DNA synthesis by blocking ribonucleotide reductase, a key enzyme involved in nucleotide metabolism. So it interferes with the production of normal nucleotides in the DNA and RNA molecules and prevents replication of these of this genetic material. If we look at the response to therapy at 1 year, from left to right, peg interferon, lamivudine, adefovir, entecavir, telbutavine, and tenofovir, you can see certainly that HBe seroconversion is relatively low in all of these drugs, but normalization of ALT is extremely high, particularly for tenofovir, telbivudine, and entecavir. Also, lamivudine is initially very effective at 1 year of therapy. The problem, as you'll see later, ultimately is not the initial response to therapy, so much so as the ultimate development of resistance. So if we look at undetectable HBV DNA and normal ALT in e-antigen negative patients, again, for all of these drugs, with the exception of pegylated interferon, undetectable HBV DNA and normal ALT is quite high, somewhat lower here for idefovir. This is at 1 year of therapy. But what ultimately determines your choice of therapy will be the cumulative incidence of HBV resistance. And I mentioned earlier how entecavir and tenofovir are the drugs of choice today, and the reason is quite clear. When you look at 1 year, 2 year, 3 year, 4 year, and 5 year resistance rates, look at lamivudine. By 5 years, 70% have become resistant. By 4 years, 67%. Compare that to all the other drugs, but particularly for entecavir or tenofovir, currently to date, no resistance to tenofovir has been demonstrated. So what do we know about these nucleoside and nucleotide analogs? Again, I've put it next to pegylated interferon just for your interest. These nucleoside analogs are safe at all stages of disease. They're safe in immune-compromised patients. These drugs are probably safe during pregnancy, and reported toxicities are rare compared to peg interferon, where there are a whole host of problems related to its therapy. In children, if we look at the HBV response to therapy, keep in mind now that the indication for tenofovir and entecavir are patients greater than 2 years of age. Up to a couple of years ago, it was 12 years of age. That is now, tenofovir is now approved for children greater than 2 years of age. The primary endpoint, HBV DNA less than 400 units at week 72. The percent reaching that endpoint, 89 versus 0 on placebo. Seroconversion, 21 versus 15 on placebo, and 0 viral resistance. Highly effective. Entecavir had similar data, although slightly less effective in reaching the HBe antigen seroconversion and low DNA level that was reached with tenofovir. How long do you treat? Well, unlike hepatitis C, which exists only in the liver, the hepatitis B virus exists all over. Therefore, the length of therapy is unclear. Generally, the minimum duration is 12 months. In e-antigen positive children, generally you will treat them for at least 6 months after seroconversion. For e-antigen negative children, treatment is indefinite. Studies have shown that 80 to 90% of E-negative patients will relapse if you stop treatment in 1 to 2 years. Resistance is not a problem with tenofovir. Histology may be important decision in when to stop treatment. I think that's particularly important when considering the e-antigen negative or pre-core mutation negative patient. And of course, non-adherence can also be a problem. It's particularly a problem in these patients because they will feel well and say, why do I have to continue therapy? And you have to sit down and explain to them why it's important not to stop. Well, let's look at predictors of surface antigen loss. There are clear racial disparities here. Whites tend to clear at a greater rate than non-whites. Again, those with the genotype, again, A and D are the most responsive, but those are no longer considered because all of the genotypes will respond equally to tenofovir. If you decline your HB-sAg level during the first 6 months of therapy, that's a good prognostic sign. And if E antigen is negative at or within 26 weeks of completing a therapy, regardless of whether it's interferon or a nucleotide. So treatment and monitoring of these patients is lifelong. Monitoring of the on-treatment response may allow for more personalized plans. Remember, long-term viral suppression improves outcomes. And we want to use the most potent nucleotide analogs. This was particularly a problem for treatment of children where lamivudine was the only approved nucleotide for patients, or nucleoside for patients who were less than 12 years of age. And so I know I personally would see a number of patients treated at another place who were on lamivudine alone. And of course, they all were resistant and became very much problematic. So we want to avoid these less potent nucleotide analogs. And again, immunologic manipulations related to genotype may be important. And again, one of the big questions remains is how do we manage both the asymptomatic patient or the immune tolerant patient? And that is it for hepatitis B.
Thank you.
Questions?
Thank you, Dr. Schwarz.
Thank you.
Nice and timely lecture, Steve. Thank you.
Yeah, you're welcome. Monday, Tom, I have a doctor's appointment at 11:30. Can we do the conference at 10?
Yeah.
Okay, so that's just Monday, not Wednesday.
Sure.
All right. And then, because Monday will be board review then, and then Wednesday is hepatitis C.
Sounds good.
All right.
All right. Thanks, everybody.
All right. Thank you.
Bye.